Well, good afternoon, everyone. We're back here at the Blanchard Valley Health System. I'm Scott Mulaney. Pleasure to welcome you here this evening. By the way, we appreciate a lot of the feedback from the last time we did this. That had a big hand in why we're sitting here again. So a goal for today, as in the past, try and provide you some education, answer your questions, be informational. On my right, Dr. Bill Coase. Dr. Coase with me last time and will be instrumental in what we do tonight. And on my left, we have a new participant, Dr. Nate Ratnasamy. His specialty is infectious diseases. So Dr. Ratnasamy has a deep understanding of this whole process, and I think we'll find his expertise is very helpful. As a layperson, just a couple thoughts from me, and then we'll get to your questions. One of the things we know about this virus is it's very easily passed. And that's one of the reasons why I think social distancing is so important. Remember, we have no immunity. So being careful is part of the key, and we've done very well in this county. We have no accepted medicine regimen. We're trying a number of things, and these two physicians, I'm sure, will talk to you about some of that, but nothing has been proven, nothing has been fully studied. And finally, we don't have a vaccine yet. We've had some questions about that, and we'll try and provide you a little bit more information tonight. But as a result, we remain quite vulnerable as a people. So with that, we're going to hop to the questions. By the way, we had 20 some of them submitted before we started. So for those of you that did that, thank you. That's what makes this kind of a session really valuable. Debbie from North Baltimore. By the way, I've been told if you're from North Baltimore, you refer to yourself as a North Baltimorean. I don't know if that's true or not, but that's what I've been told. By the way, from a person who's from North Baltimore. How many of our Findlay, Hancock County residents have been tested for COVID-19? And what are your plans to continue testing? Have we hit the peak yet? And do we still have a fight ahead of us? As I said one time last time, that's a lot of questions in one question. I think there's 4 there, but I'm going to turn it over to Dr. Coase and let him take a crack.
I think Nate's got.
Oh, Nate's going to handle it?
Nate's got the statistics.
I've already messed this part up, but go ahead, Nate.
All right. So we've had 2,000 calls to the triage and testing center. And of these 2,000, 325 people have been tested, and people have come from 15 surrounding counties. And we've had 31 tests come back positive. And these, by our count, we have 23 are Hancock County residents. And, you know, we can expect to continue staffing this triage center until things look like we don't need to maintain a separate center for testing and becomes part of regular routine care. And we have seen a slowdown in some number of cases. We're having about 8 to 10% of our tests turn positive. And, you know, it still can change and turn for the worse. So the best thing is to maintain the distancing measures to keep safe.
Any further comment about that?
No, I don't think so. I think if we get into it, we'll talk more about the non-pharmacological things we can do that are still really important. Social distancing, quarantine, things like that.
Okay. Next question, Denise from Findlay is asking, how many COVID-19 patients have been admitted to VBA?
Again, Nate, I don't think we have anybody in right now, but
Nope, we have 3 people that are being observed and waiting on tests. And we've had a total of about 8 admissions for COVID positive.
have those, Nate, been pretty sick, or what are we seeing? Are we seeing gamut of and what's the criteria that people get admitted rather than we send them home?
The main things are oxygen levels. If they have unsafe oxygen levels and need extra oxygen, some of them have had low blood pressures. Some have had other issues with underlying health problems. Many of them have heart disease and COPD and kidney disease. adds another stress to their body. And so there's decompensation and we have to support them.
I saw somewhere where 90% of the people that got admitted in general have comorbid conditions. But that doesn't still, if you're young and healthy, you still could get it, but certainly going to make it more probable.
Yes, if you have comorbid conditions, so existing high blood pressure, diabetes, heart disease, much more likely to get seriously ill. Whereas younger people, less likely. But if you look at New York City statistics, the 25 to the middle age is still about a quarter of the admissions to the hospital are in the younger age.
Elijah from Macomb is asking, has COVID-19 spread through Hancock County the way that was predicted and expected? Good question. Coach?
Well, this is back to the modeling. What did we expect to see? And depends on which model you used. I would say this, that it would have fit a predictive model. The thing that I think has surprised everyone has been how important social distancing is. So going back to Scott's original comments, you have a virus. There's only so many ways that we can protect ourselves as a human. You have a virus that is very contagious and we don't have any immunity. So if I get the disease, then I'm probably not going to get it again. That may come up made as a question, can you get this again? I get asked that. We don't think so. So you can either get it from being infected, we can develop a vaccine, which we don't have. And right now, with no immunity out there, everybody is very contagious. But the other way the virus can't infect me is if I'm not around it. So built into all of these theoretical models, they're really what I call natural experiment models. Individuals go back after the fact and look about how the virus acted. I don't think anybody expected, and when we saw the surge data, when we saw how many we were going to see, that the effectiveness of people staying away from each other was more than what would be expected. Therefore, if you look at the model, we expected a surge that could have happened anytime. Right now, this could have been the peak. We're not seeing the peak because people have stayed away from each other. We've quarantined nursing homes, schools have been out. So I think it's predictive of the model, but it's not what everybody may have thought was going to happen. Yeah, I don't know, Nate, if you add anything to that.
No, I think, we have to act based on what is known of the virus. And, obviously it has had a lot of consequences, social area, the business area, and it has saved lives.
Thanks, guys. Don from Rawson asks us, what estimated level of preparedness would you say the hospital, and I'm assuming that means Blanchard Valley, Finley campus, at this point is in relation to any potential surge of COVID cases? And how does this compare to the level of preparedness prior to the start of the event? I'm going to take a crack at that one. We set up something called an incident command. We're treating this as a disaster. And there is a well-defined national approach to dealing with disasters. It starts with incident command. Our leader is a guy named Ryan Shoemaker, and Ryan and his team of section chiefs have done a fabulous job of building us plans to deal with surge. How much better prepared are we now than we were a month and a half ago? It's almost unbelievable how much better prepared we are. We have all kinds of plans available for varying levels of surge, all the way up to and including, if we had to, taking patients to other nearby facilities where we could take care of them. So we're in great shape in terms of being prepared now. And that's a testament to Ryan and his team of people that spent countless hours, and I mean countless, coming up with plans to ensure that if the pressure's on, we're ready to respond. I don't know if either one of you would want to respond to that.
I completely agree with Scott. It's probably the one time in my life, and I'm elderly, that there has been a real change in my life of what I've done. I was thinking about that as compared to 9/11, the recession. I just don't even remember what it was like 6 months ago. We literally had hundreds of hours today that were put in on planning for COVID. We had several meetings that we started late. I had a conference today with, I think we had 70 some of our physicians that he was talking about cases, what medications to use. Scott and I started at 6:30 with Ohio about what's going to happen when we open back up surgery. We've been meeting with nursing homes. We've been meeting with the community where there may be between 10 and 12 people on. So I think our preparation is, I don't know what more we could have done. It has been nice that the surge didn't come as quick as what we thought, but right now we feel pretty comfortable with where we are with whatever may happen over the next months or so.
And hopefully we don't see a surge, but if we do, we're ready. Leah from Benton Ridge is asking us, is Blanchard Valley Health System still in need of donations of PPE and other supplies? Bill?
Well, we're always looking for help. We are in fairly good shape related to PPE from a standpoint of masks and shields and things like that, but we're not sure what will happen depending on surgeries and things like that. The one thing that I will say that the masking has become something that's symbolic. I think it's probably important. It keeps me from touching my face. It probably is helpful. But I'll ask Nate what he thinks, is if we start to open back up society, specifically in this community, I think the more people that are wearing masks, the better. So I would encourage those of you that can make a mask. It's not that hard. It may not be something that meets all of the criteria for aerosols, et cetera. But we are in good shape. To answer the question, we are starting to get those out to the community. Great concern about individuals in shelters that they need to have masks. The health needs to have masks. We need to have people at least wearing masks. Hopefully that doesn't mean they're going to quit they're going to forget to quit, that they need to keep washing their hands. They need to social distance and do things. But yes, we can help. And I think if you got a number there, Scott, or Marie Sway's good, I'll make sure.
Actually, we do, yeah. To the extent you'd like to talk about donations, Marie Swaysgood is our Chief Development Officer. You can reach her at 419-429-6414. Dave from Arcadia asks, this is a good question. I heard Governor DeWine talk about the plan to begin elective surgeries again. I need knee surgery. Is there a projected date for you to begin performing these surgeries again? This is late breaking news, but I was on a phone call literally right before I came in here from around the state, and it sounds like somewhere around May 1st, the governor is hoping to have some plans in place to reopen elective cases. Now, I have to be very general here because we don't know how many, we don't know where, we don't know exactly what that means, whether it would be all elective cases or whether there'll be selective elective cases. We'd like to think it means both pain management procedures as well as elective surgeries, but there's more to come on that. And I can tell you there's daily activity going on between our association, the Ohio Hospital Association, the Medical Association, and the governor talking about how to safely do this and try and avoid a spike in any transmission of the virus. Either one of you guys want to comment?
Well, I would say this, and this would be if this were myself having this, what would I do to get prepared for that if that were to occur? We still have not seen nearly the number of individuals infected that what we would have expected. And there is, again, going back to Scott's initial comment, which is really important, before we get to 50 to 70% of the population with immunity, and right now with no vaccine, that means that number of individuals have to have been infected. There is a high probability that you could become infected. You certainly don't want to be having knee surgery or anything else if there's a high probability of getting infected. Now, with that being said, we haven't seen too much here. We have done as much as what we can, we think, at the hospital. Anyone that comes into the hospital, we're taking temperature, we're screening them, we're asking, have they had any respiratory kind of problems? The same way with our staff. If they have infection, they're not going to be there. They're wearing protective gear. One of the things that I'd be concerned about if I were having knee surgery, a major surgery, is what kind of rehabilitation are you going to need afterwards? You're going to need exposure to a lot of people that also are going to need to be predictively negative as far as having the problem. So maybe I'll turn it back over to Nate from a standpoint. We were talking before we came on that you saw today that 44% of the transmissibility or individuals that have become infected may have been from someone that they did not know was even sick. And in fact, meaning that they hadn't started to have any kind of symptoms. So if we're going to start opening surgery, what kind of things would you get ready for? Would you quarantine yourself for a few days? Would you make sure you wash your hands 6 times a day? What kind of things should we, or what should we set up here as criteria before someone would come in? And again, hypothesize.
Yeah, I think one of the things, as we get more testing available from an antibody standpoint, that's going to be helpful in helping screen people who may already be immune or who are susceptible, so we know what precautions.
Can you explain what that means, antibody testing?
So you can diagnose this infection by what we've been doing is called the PCR method. So if you think of a security camera that catches a burglar red-handed, you can say, yep, guy looked 6 foot tall and wore a red shirt. That's PCR. Now, if you don't have a security camera, you walk into the house and everything's a mess, and you see a window broken, you say somebody was here, but you don't know who, what, how many, and so on. But you know that it's a burglary. So that's the difference. The PCR test says we know which virus it is, and we can pinpoint it. The antibody test looks backward and said, yep, this virus was here. And so we can be specific about it, but blood tests sometimes can be fooled. So that's why we need to be careful about using those blood tests as well. But that's going to help to know who's been exposed and if they're immune already.
And what percent of the population?
So if I have the antibody, then the presumption is I've already had the infection,
Right.
and I'm not going to be able to give it to someone, and I'm also not going to get it yet.
We hope.
Yeah. Now,
So
why don't
that-
you elaborate a little bit on, because Nate and I are getting lots of questions about these. We got one this afternoon about how come an airlines can check everybody and that the United States can't. Do you have any comments on just the test? How sensitive and how specific are these tests going to be? That's a big concern to all of us.
There's a lot of reports of the antibody tests coming, and right now, under the emergency situation, FDA process has been relaxed to allow tests to come out onto the market without the stringent testing that they normally would go through. And so we've been carefully sorting through. We're looking at a possible test that we will get through Mayo Clinic that has gone through more stringent processes. And it looks like this particular test we're considering will have about a 5% false positive rate. So it could be another related coronaviruses. We know there's been 4 main types of coronavirus in circulation causing colds. And so we want this blood test to be able to pick out, did you have SARS-CoV-2, which caused COVID-19, or did you have one of the other 4? So we want a blood test to be fooled. And so we're trying to be careful in picking these tests.
Good. Thanks on that one. We got another question here from Marion from Arcadia. When will things get back to normal? I'm going to make a quick comment on that, and then maybe invite one of these two to comment. I think it's a big stretch to believe that we're going to get back to normal for some period of time. Until we either have herd immunity, which is what we were just talking about here, or a vaccine, we're going to have to continue to find ways to not make it easy for the virus to pass between each other. I'm a big sports guy. I love particularly college football. I know this is hard to imagine, but thinking about putting 80,000 or 100,000 people closely sitting together in a football stadium before we have a vaccine, I don't think it's going to happen. I think restaurants that we're used to having 200 or 300 people in them, I don't think that's going to happen. So whatever you mean by the word normal, and I also think people are going to be afraid. I think a lot of folks are going to say, I don't want to go sit 2 feet from somebody I don't know in a restaurant. I don't want to have somebody basically sitting on my lap in Ohio Stadium. I just don't want to do that. So I think our governor is well aware of that. I think governors all over the country are well aware of that. Trying to figure out how do we reintroduce activities that we can do that we believe can have a higher level of safety than some others and can seem more normal than being quarantined to your house, basically. So that's one way to think about it. Bill, anything to add?
No, I completely agree. And when the question's asked, well, what's normalcy? Is it from the standpoint of the medical community, from the standpoint of healthcare? I think we're going to certainly have to get to that 60, 70% before we're going to feel comfortable with someone walking in and being treated. Is normalcy related to social behaviors? I agree with Scott. I think it's going to be a while before people act the way they did before. And then normalcy also could be economically. You could ask that. I think it's going to be a while for a lot of reasons related to what Nate talked about, the unemployment rate. People are going to owe a lot of money, so that we're going to probably see some changes made that way. But as I'm going to emphasize again, as we flatten out this curve, where Scott, we have pushed this back, that there's going to be more individuals getting sick later than what might have been expected.
The next question kind of gets into that topic. Susan from Portland, Oregon is asking, if we open up society, what's going to happen and when's it going to happen? And I think this wave theory is kind of interesting. Maybe you can talk about that, Nate.
Yeah, as we talked about in epidemiology, we talk about a factor called R0. And that is one person can infect several. And for this particular virus, the range has been around 2.5 to 3. And so that means if an infected person gets out into a crowded stadium or a restaurant, potentially 2 to 3 people are at risk. So what this flattening the curve has done is lower that ratio. And as we take precautions, we hopefully will keep that low. And as it gets to 1, the infection doesn't propagate. But again, that has to be some changes in people who have acquired infection, acquired immunity, or vaccine to bring that R0 rate down. So if we're not careful, the rate can shoot back up. And as we've seen in the cruise ship and even in the aircraft carrier recently, where 600 of the 4,000 some sailors were found to be positive in that confined environment, they could take off again.
So what do you think our strategy ought to be? If, okay, we're gonna, let's say it's opened up, and I don't think it'll be completely opened up, but then we start watching for cases, and then we have to clamp back down for social distancing, or I know we've got to be able to follow contacts, and having testing would just be a game changer for all of us, at least to make predictions. But it's still pretty gray out there for me. What we ought to do.
I think we're looking at having access to testing, and also more people recruited to do the contact tracing. Right now, the public health departments have not been as strong as they were back in the 50s and 60s, when polio and tuberculosis and other diseases were a big concern, and public health was strong. As those infectious diseases dropped down, public health staffing went down, and so now we're going to have to revisit that and beef up the public health departments to be able to go out and do that contact tracing and find the contact of contacts and test and bring in the contained infection.
Let me ask Tammy, are we getting any comments, questions we need to hear live?
We had just a couple in regards to treatment. How would we treat someone with COVID, and what is the average length of stay for an admitted patient?
I'm not touching that. You guys can handle it.
Nate, Nate's seen most of the people that have come in. And,
So basically here at Blanchard Valley, we have a multidisciplinary rounds. That means that all the members of the team get together every morning and discuss everybody in the hospital. And that's being either tested for COVID-19 with pending result or known positives. We have had some longer stays, 10 to 14 days, and we've had some shorter stays. I can't give you an exact average right off the top of my head, but probably 4 to 5 days I think would be pretty typical. And treatments, right now, do we have hard data to support one treatment over another? Unfortunately not. Those tests, those studies are in progress. Some of our
Despite what President Trump tells us.
That's a political question.
I can't help myself. I'm sorry. I apologize for that one.
We have tried the azithromycin and hydroxychloroquine in some people. The problem with trying these treatments, for most people, they're going to get better. 80% of people get better and don't even end up in the hospital. So I can give M&Ms to those people and say the M&Ms made them better. I know I feel better with M&Ms. But we can't say that's a cure. So we have to be careful with association and causation as to what exactly is working. And the chloroquine, hydroxychloroquine trials have been, the more numbers we get, not as strong as we'd like to see, but there's still more trials coming. So we'll see. Besides that, there's many other things that are in the works. Plasma is probably going to be helpful in the short term, and that means getting antibodies through a blood donation process, taking out all the cells and just having the plasma part of the blood, which has the antibodies. So you find people who have the infection, have positive antibody tests, and borrow their antibodies and give them to a sick person. And that's used for rabies to help protect people. We have used it for Ebola. We have used it for pneumococcal infection. So it's been around, and that is being studied for this as well and showing some promising results. So there's some other experimental drug that's showing some benefit called remdesivir. Not great, but some benefit. And there's some other antibodies directed against interleukin-6 receptors, which calm down the storm, the chemical storm in the body. And that may have some benefit as well.
How about zinc and vitamin C? That's two that are they're cheap, I think.
Well, you read about them a lot.
Yeah,
Sure.
everybody's talking about.
Yeah, they've been around, and people have used them for colds, and coronavirus certainly are part of the colds. There's some benefit to shorter symptoms by a few days or 1 or 2 days with these medicines, so they may help with this as well. Again, part of the study.
Those are probably ones that aren't going to hurt anything.
Just a comment to everybody out there that the way I see that a lot of the treatments become somewhat politicized because of what lots of people have said from lots of different vantage points. Generally, doctors, if we had a good treatment, we would use it. As Nate said, we'd like to have trials. You can't always wait for trials. Science doesn't act that quickly. We'd like to be able to show that there was some real benefit. And I know that our doctors here have used those medicines, as Nate has said. We've had conference. In fact, we had a conference today for half an hour with the physicians that I talked about. What are the best treatments out there? So it's not like we don't want to do it. There is some real concern about the hydrochloroquines because there are individuals that are on that need it for anti-inflammatory reasons, and apparently it's getting difficult to obtain for individuals that have been on that or should be on it because of the widespread use. So it would be nice to be able to show that it really is effective, and we're just not there yet.
All right, guys, we got a lot of questions to get through, and we're we're gonna have to be.
Well,
a
you're
little
talking
more
to two
efficient.
interns.
I understand.
We don't answer anything in one sentence.
That I can assure you folks is true. Margaret from Finley asks, I saw in the news that you built some negative pressure rooms. Quickly, what does that mean, Nate?
Okay, so the simplest answer, keep it short. Normally, if you open a door, stuff can come from within the room out into the hallway. So we don't want flying particles coming out of the room. So you put change in engineering so that air is being sucked into the room and not coming out.
By the way, we set up a fund to help us during these times. Some of those dollars have gone to help pay for some of those fans. So much appreciated to all of you who supported that.
Yeah, I think we started with about 8, 10 rooms, now up to 29 isolation rooms.
Yeah, that's fantastic. Rashmi from Finley asks, I see that you've begun providing telehealth services. How many telehealth visits have you performed? Is this a service you plan to continue once COVID-19 is concluded?
Well, we've
What do
done.
you think about that one?
Well, I'm an old internist, and that's not the way I would have preferred to practice, but we have tried to adapt. We've done over 5,000 of those through our medical practices, and I think all of the other practices in Finley have begun that experience. Part of it is seen, I think, by a lot of the physicians as not a stopgap, but in the meantime, until we get back to whatever normalcy is that individuals can come in, we need to check in with them. I think we are also starting to investigate some of the technologies that could be there, listening to your heart, looking into your throat. It's not just talking to someone as to what their symptoms are and trying to diagnose without some kind of a physical examination. So I think we will continue that, certainly in behavioral health. That has been used, and I think it's going to catch on. I think patients have accepted it from what we've understood really well, and the
We just need
doctors have
payers
adapted.
to accept it, right?
That's an issue. I know, Nate, have you been using much telehealth? Has it worked out pretty well?
Yeah, again, it's not the ideal situation, but more than just the voice on the phone, you can see an image. You can see how, just the general look of the person, and if a person has a wound on their foot, some of the people are very adept at pointing the camera at the wound, and I have a chance to look at the wound. It's not the same as listening to a heart or feeling for tender areas in the abdomen, whatever. It's not the same. It's not going to take the place of, but it can be a bridge.
Good. Dana from Finley's asking us, since BBHS now is a member of the Mayo Clinic Care Network, how has that helped in the treatment of this pandemic?
Well, we've got the world's best experts as consultation, so we can really get on the phone. Nate mentioned just looking at what that they're doing with antibody testing. We talked about maybe a one-day turnaround, which would be super. We still have the availability of e-consults, and since meaning that Dr. Radnasamy could talk to an infectious disease expert at the Mayo Clinic as an opinion, and since we're not sending people, this becomes even more invaluable. And then we're also using it for medical education, so it's worked out from our standpoint. This is great.
And we know the clinic is working very hard on testing, on vaccines, on treatments. So we're at the front of learning what they learned. It's pretty exciting.
That's the good housekeeping stamp of approval.
Chelsea from Finley is asking us, this is an interesting question. My baby is due in the first week of July, and I want the baby to be born in Blanchard Valley Health System. What extra steps do I need to be taking for the labor and delivery process, and what differences can I expect?
I think just as anybody coming into the hospital right now is being asked questions. Are you having any respiratory symptoms and so on? Being checked for fever. We've had to limit visitors, but for OB, certainly a support person, if they're feeling well, will be allowed. So there's going to be some adaptations, but we still have the same team in place that does the deliveries and expect to continue with the high quality care.
Yeah, but I would be really hopeful it'd be quote unquote business as usual. July is going to be interesting because hopefully we will have opened up our society a little bit and done so very effectively. But we'll definitely, one thing's for sure, your doctor will definitely be keeping in touch with you. Other caregivers, they'll be involved in your care. So please don't worry, you will be well communicated with. That I can promise. Carol, this next question, I'm going to need some help. Carol, I don't know who you are, but you've got a bunch of words in here I don't know how to say, so I'll do my best. There hasn't been time to conduct research on the drugs currently being used to treat the virus, and you've already heard that. However, with no alternatives, doctors are using them to treat patients with very good results, especially if administered early. What is the hospital's protocol in using these treatments? And then she says specifically a bunch of drugs I can't say, so I'm not even going to try. The gentlemen here on either side of me have those words, and I think they probably know what they mean. So, either one of you, I'd love to have you take a crack.
Well, I think Nate has really talked about a lot of these. There may be a couple of other specifics, and some of the drugs that are out there are on protocols which we wouldn't have the availability for from a standpoint. The only thing I mean, there's a comment, doctors are using them to treat with very good results. I don't know that we can actually say that. As Nate said, there's a lot of people who are getting better. 80% of people don't come to the hospital. As far as I know, they're not being treated, so they would be getting good results too. And so I don't know if you've got anything additional to say to that, Nate. There are theories out there. Hydrochloroquine is the one that's talked about. Gee, if you get this on people really early, don't wait until they're completely sick with ARDS or being on a ventilator that you get better results. But again, trials have not proven that.
Yeah, and anytime, when we do what's called an open label with only one arm to the trial, that means you don't, you just use one drug and you know what it is. There's no blinded, so the researcher doesn't know what they're giving the patient, keeps his biases away and so on. It's hard to interpret. There's classic results with what we call placebo trials, where you can give people blank sugar pills and M&Ms and 30% get better. So we have to be careful that we're not having a placebo effect, that people think they're getting something, and just that belief sometimes does get people better.
Thanks, guys. Karen from Finley asked us that she saw in the news that the Mayo Clinic reduced the salaries of 20,000 of their healthcare workers to help control costs. Is this something Blanchard Valley is considering? To answer that, let me give you a little background. For us, and this varies somewhat across the country, but it's pretty consistent in terms of being directional. Our revenue, because we're not doing elective procedures, and because people are staying home and not coming to see the doctor, not coming to the emergency department, has been disaffected by something in the vicinity of 60%. So far, we've tried our best to maintain everyone's salary where it was. So, for instance, this month we're projecting a variance from normal of about $13.5 to $14 million. And it doesn't take a genius to know we can't do that for very long. The question is, what do you do about that? And lots of organizations have done all kinds of things. There have been pay cuts, there have been layoffs, there have been organizations that have decided not to contribute to pension funds and 403B plans. They've frozen hiring, all kinds of different decisions made to try and help reduce costs. We are in the process right now, Bill and I have actually spent a lot of time on this, looking at options, trying to figure out what's going to be the best set of decisions for Blanchard Valley Health System. One of our strongest capabilities here is culture. The corporate culture here is one I'm very proud of. I don't hesitate to say that. We have a fantastic bunch of associates here. So trying to maintain that positive culture, maintain the good spirit to do what needs to be done for the people who entrust us with their care is paramount. It's job number one. So how we do that and resize our expenses so that we can live, at least limp along until some more normal state occurs is a big, big, complicated question. One of the reasons why we haven't made any of these choices so far. In the next probably 2 to 3 weeks, we're going to have to. I would say everything's on the table right now. And we're just going to have to use our best judgment as a group of executives here. Kurt from Finley asks, how are you using the funds donated to the emergency response fund? Is there need for additional monetary donations? The second question is a decided yes. The first part, pretty much have already answered. Most of that money has gone to help create the fans that allow us to have negative pressure in so many rooms, which, by the way, is a really beneficial thing. And it's one of the reasons why women can safely come here and have babies and not have to worry about this. The patients, should they have this kind of a virus, are going to be in a room where that gets sucked out of their room and out into the normal air. So again, for the people that donated, we thank you very much. Once again, if you'd like to, the number is 419-429-6414. Carolyn from Miller City is asking, regarding patients who test positive for COVID and are admitted to the hospital, what treatments and medications do they receive, and do these assist in their recovery? We've kind of touched on that, but maybe you can.
Well, I'll add, it's pretty much supportive care when someone comes in. And so we're concerned about, as Dr. Radnasamy said, their oxygen levels. So we may be putting oxygen on and watching them, watching for deterioration of vital signs and things like that. In addition to some individuals may have gastrointestinal symptoms, so they need IV fluids and things like that. I think we have covered the medications. One of the treatments sometimes are aerosols for respiratory problems. You want to comment on that? I don't know, that's controversial, but are we spreading the disease and et cetera?
Yeah, so the nebulizers, people with asthma are very familiar with that. Basically, we've avoided using those kind of treatments because the respiratory secretions will get flung around. And so instead, just using what's called a meter dose inhaler, which is just a squirt of.
It's flung around, is that a technical term? I like that.
I could use some other terms.
No, I think everybody understands. Christine from Ottawa is asking, do you believe BVHS staff has risen to the challenge of COVID-19? Nate, you're in the middle of it. I'll let you take a crack at that one.
Yeah, I mean, this has been an absolute privilege to be part of a team that has worked so hard at every level. And, you know, from, infection control, Colleen Abrams, to all the physicians and nursing staff and respiratory therapists, physical therapists. It's been a huge effort. And the incident command team has done great, hospital administration, and not only just at the hospital campus, I think throughout the community. Our leaders from Mayor and County and Hancock Public Health, it's just been great to see this community come together and really fight this thing.
I agree with that.
Good. I would too, for what it's worth. Delma from Finley, and this one's for you, Nate. Please explain what a probable case is compared to a confirmed case.
I think just as the terms imply, when you have a blood test that says, yep, they got it, it's what we consider a confirmed case. The category of probable case is another statistical tool to say, the blood test didn't come back positive, but there's fever, there's shortness of breath. They had a family member with COVID-19. So this certainly is acting like it. And either we didn't do the test or the test came back negative, which could be a false negative. It still fits into that basket of probable.
Margaret from Pickerington, Ohio. I think that's a suburb of Columbus, isn't it?
It is.
Well,
A little context to this question.
when do you think we'll have an effective vaccine, and why is it taking so long to develop? That's a terrific question. So I'm gonna let both these gentlemen take a shot. No one should go first.
All right, so there's some context around this question. This is from my mother. My mother is 96, as she reminds me, 97. I'm going to be 97 pretty soon. She's in assisted living and she is socially isolated. She has 4 sons. We try to talk to her on a pretty frequent basis, but she hasn't been able to see anybody for the last 4 weeks. She also contextually has another son, besides myself, that's a doctor, that's an intensivist, takes care of people that are in the ICU. And invariably, when I talk to her on the phone, she asks, "You doctors, as smart as you think you are, how come you can't come up with some kind of treatment and a vaccine of what to do?" So I have tried innumerable times, Nate. So maybe you could give her an answer. Why can't we get a vaccine within a year or so?
Well, I think, the vaccine work started as soon as the RNA sequence of the virus was known. So once the genetic structure of the virus was first described in January, a lot of people have started to work on the vaccine. So it's finding a target protein that the body will go after and then make antibodies against. So each virus is just a piece of RNA with a protein coat around it, and each virus makes its way into a cell and makes more of itself and then gets out. So to block that process, the body has defenses. So we have to fool the body into thinking an actual virus is around, and so that the body will make these proteins called antibodies and fight off the real thing when a real virus does come around. So the process, so that technology of finding the right target is the first step, and then having it delivered into the body safely, and then having a few people try it out and see if they respond in an appropriate manner, and then taking it to larger trials to make sure it's safe and no unforeseen side effects. So all that takes a little bit of time.
And what do you, realistically, we probably talking about a year?
Yeah, probably next, maybe late this year, probably next year.
Which is one of the reasons why, for what it's worth, I tend to be pessimistic about how much we're going to be able to open up society. The fact that we don't have much of it around here is because of social distancing, not because the virus isn't here. And until we get a vaccine or get immunity, I think we're going to struggle with this up and down. Lori from Grand Rapids, Michigan asks, if a vaccine becomes available, this is a great question. You think it'll be mandatory? And this is just an opinion question, but what do you think?
Well, that's a political question too. So my,
Well, you're good at politics. Go ahead.
well, the answer to that would be whether the government could make it mandatory. Scott and I were talking earlier today. I can remember the polio vaccine. I don't think anybody, my mom or dad, signed any informed consent. I think they just lined us up. We got the shot and took the medication. That's the way it was in the 50s. The society is different. We have, and because of the immunity of measles, mumps, and all of the other polio Nate mentioned, smallpox, smallpox is pretty much gone because there's so much herd immunity, meaning that 90-95% of individuals have antibodies. There are individuals that don't have to get the immunization or the vaccination, and it in general isn't a problem, although we've seen outbreaks of measles and there are other things that can occur. So with that being said, I think that there will be a push. Certainly if we have a safe vaccine, that's what everybody wants. That with what's happened, most people are going to say, I want to get the vaccination, just like what they do with the flu shot. But if I had to predict, I think there will be religious exemptions and there will be exemptions for medical reasons. And so it will not be stated mandatorily that everyone has to get this. The question about the will it be if you want to go back to school, that one I kind of think that there will be probably pretty if you don't want your child to be vaccinated, that will still be up to you, but my prediction would be they won't be able to go back to school. I don't know how you feel, Nate, but
Yeah.
it's a societal question.
Yeah, and I think, ideal, I would like to say, here's the evidence for doing it, and have a person consent and say, yep, I agree, and do it. That's normally how a relationship should be. But, there's certain things we've just had to mandate. Seatbelts.
So we'll keep an eye out on that one. It's a great question. Mandy from Finley's asking, this is a really good question too. I bet there's a lot of people that have this question. I have a 2-year-old at home, or a young child. How is this virus affecting children? And what do I need to do? What can I do to protect my child from the virus?
Children have been infected. There have been deaths reported, but it's not a common occurrence, fortunately. So children may be in that group of people that have very minimal symptoms. And there's a lot of infections that kids, younger kids especially, get off pretty light. You can think of common infection in many developing countries, hepatitis A. Many of them don't have any symptoms, but they're immune, and that's because the food and water they're exposed to early in life is they get the infection, and they don't turn yellow and all that, and they feel better. Mononucleosis, a common infection that probably 80% of the population has had. Many people don't recall ever having the typical mono, but if you do the blood test, they show that they've been exposed. So
For some people, they get seriously sick of it too, right?
yeah, mononucleosis can be a very serious infection for some people with liver involvement or other complicated anemias or neurological problems.
So you think part of that would be the comorbidity? Well, let's say the child is 2 years old and has asthma or recurrent, something like that, and then that it would just stand to reason that that's going to increase the probability.
Probability. Yeah.
What do you got for us, Tammy?
We just had a question about how we are handling things at Birch Haven to make sure that our most vulnerable citizens are safe.
That's a wonderful question, and either of you could.
Well, I can start out by that. Right at the beginning of the crisis, from a standpoint of planning, there was a real concern by everyone in the community about those individuals, not just in nursing homes, anyone in any kind of shelter. So, as I mentioned earlier, we spent time trying to figure out, for example, the city mission. Specifically, the governor closed down nursing homes, as I mentioned. I think it's been over 4 weeks now. And the idea behind that was if the virus can't get to someone, you can't get infected. So we have gone through really strict protocols of training, of checking individuals that work as they come in, again, temperatures being checked twice a day, making sure that everyone washes their hands. There's plenty of sanitizer available, that everyone understands what the rules are. We're trying to make sure that individuals aren't overworked. I mean, that's a real concern with what's happened in other places with the surges, is that healthcare workers get sick. 10 to 20% of all of the cases that are out there now of individuals that have been sick with COVID are healthcare workers. We're exposed. That's what individuals on the front line, Dr. Radnasamy, they're seeing these people all the time. So we're trying to make sure that they have time off, that they take care of themselves, they eat well, get plenty of sleep. So we're doing as much as what we can in addition to those protocols. So I think it's been really thought out well. It doesn't mean that there isn't something that could happen. Again, if 40% of individuals could be transmitting this and don't know that they have it, it's probably going to occur somewhere, that someone is going to be working in any kind of an institution, that they're going to be a carrier. So I don't know if you'd add anything more to that from public health or from the standpoint, but that's what we've done with our 2 nursing homes. And I can also say, having been on phone calls with the nursing homes in the area, we are all in the same place. We're trying to shelter it in place, meaning we don't want them to have to leave to come to the emergency room is an exposure to not only to the patient, but the family that's going to come, to the EMS, to all of the individuals, and the exposure is a two-way. So really, I think we're about as prepared as what we can and have a good plan in place.
Sammy, you got any others? Wow. Guess what? We're once again right about at that 1 hour mark, aren't we? It's been a honor and pleasure to be with these two gentlemen and hopefully to provide you some additional information. I'd like to remind you we'll be making a survey available. We'd really appreciate your feedback. Now that we've done a few of these, it's actually a fairly easy thing for us to prepare for, and we're happy to do it if it's of value to you. We exist to serve the healthcare needs of this region. And if this is of value and this is something that you believe helps you and provides you information, some comfort, whatever it might be, we will be more than happy to have a third version. If not, tell us. We don't want to waste your time. And so with that, anybody got any final comments?
I don't think the Buckeyes are going to play this fall.
I don't know about that. I'm really worried about team sports. I really am, because I don't know how in the world athletes, male or female, in a team environment where they're in locker rooms and on a field of play near each other. I just don't know how that's going to work. And even if they do, I can't imagine going to Ohio Stadium and there's only 2,000 fans there, or whatever the number would be, to have them socially distanced. So I think it's going to be really strange.
So we're just trying to prepare you all out there.
Yeah, they call me Sunshine Scott for a reason. Once we have a vaccine, I'll feel a whole lot better about all this.
Agree
So
with you.
please be safe. Please understand that the social distancing is a real key to this. And it's very good reason why we've done as well as we have in this area. Thanks for tuning in, and give us feedback, and we may or may not see you again. Take care.